in the best best of myself at this point, but I appreciate you being considerate. So let me share my screen. So okay, okay. Thanks for that. So why do I do this? I'm currently who I am. And my name is Zhe. I'm currently serving as the informatics lead um, at UF-FSU Clinical Translational Science Award and in our Biostatistics, Informatics, and the Research Design team. And I've been providing support to FSU colleagues for accessing electronic health record data and also using the health record data for secondary reuse in research projects. But we haven't seen a huge volume of researchers, a huge interest of researchers using this type of data for research or for research proposals, grants. So we think that it's really important for us to in giving a workshop like this to kind of educating our colleagues and students about the use of electronic health record data for a variety of purposes. So today we're going to be focused more on building prediction models with EHR data, but it doesn't mean that EHR data can only be used for for building prediction models. And with me today, we have my colleague, Dr. Balu Bhasuran. So I'm gonna let Balu introducing himself.
Hey everyone, nice to meet you all. I am Balu Bhasuran, currently a research faculty at School of Information. I work mostly using electronic health record and clinical notes to deploy prediction models for early diagnosis and machine learning based predictions for various health outcomes. The goal is to improve patients' life in general. Yeah.
So Balu has been working with me for more than 2 years, and he was initially before he joined FSU in 2023. He was a postdoc scholar at the UCSF in San Francisco, and working with a physician, clinician, scientist. They are focused on rare diseases, using electronic health record data. So since he joined my lab, actually we've been working together on several research projects on HIV and also on pediatric transplantation. Um, so um, so he definitely have a lot of experience using EHR data for research. So I'm gonna co-presenting this workshop with him, and he'll be presenting some case studies showing how we use EHR data for prediction modeling. So before we get started with the content, I want to mention that this workshop is a 90 minutes workshop. It's a kind of long presentation, and we're trying to make it more interactive. So if you have any questions in the middle of the presentation, please feel free to stop us. And we'll be happy to entertain any questions you may have. And at the end, certainly we want to also leave some time for question answering. And if you have also will have time, I can also show you some materials we have developed for a program called AI Passport, which is our 25 program for educating biomedical and clinical researchers to use AI for research. So so here we go. Quick introduction about our bird team. So we've been around for about 7 years, since 2019. And the bird team is is a central support team for biostatistics, informatics, and research design within the UF-FSU CTSA. And we do have several systems on running, including a recently updated website for the CTSA bird. So if you don't know how to find us, you just type ctsa.fsu.edu and go to resource, and you can find our CTSA bird resource there. And we have a group of teams that are focused either on biostatistics and research design and informatics and qualitative, quantitative, and measurement development. So it's a mix of expertise from different fields, but we're all here to help you kind of with your research studies, especially if you have studies that needs stats support or biostat support or informatics support. So we do also have a ticketing system. So if you have any needs for research, you can go to fsuhealth.fsu.edu and find biostatistics and informatics support, and you submit a ticket, and we'll be working on your research request accordingly. And these are just listing some of the research support we're providing on clinical translational research design, biomedical informatics database access, informatics and data analysis, quantitative, qualitative, power analysis, data analysis plan, statistical design, data cleaning, survey development. So it's a mix of things. So if you're not sure, if you need our support, please also feel free to reach out to us, and we can always find someone to help you with the research. So we also are maintaining several assets, including a Canvas website. And this Bird Canvas website is hosting our previously conducted workshops, and also the materials we have generated for supporting people to understand how to use one Florida data and some other data assets. We also can support researchers to use other data resources such as All of Us. And this Canvas site is a self-enrolled Canvas site. So you just have to enter this URL to your browser, and you'll be directed to a web page where you just enroll by yourself, and you can get access to the resources. And currently, we're using this website as also a way for communication. So whenever we have any particular opportunity for education training, we also send information there, so people will be able to get information about bird-related activities, events there. And in the future, we're changing our communication plan. So the CTSA will create a more centralized channel for communicating information about CTSA activities and events in the future. And we also have some, these are some of the available content that are currently available in the Canvas site. So if you're interested in, kind of enrolling, please feel free to do so. And let's talk about health big data first before we delve into the use of electronic medical records. So healthcare big data is a complex and multidimensional kind of realm. It includes different type of dimensions. We can categorize data into different types of data. Certainly, some data are collected at point of care, and some data are collected after care. Some data are collected at home, and some data are collected, within a social economic status and the environment. And so these are just some of the information that can be used for secondary reuse, like medication. You can have a prescription medication. You also have dispensing information. So the dispensing record and the prescription information can also be found and to be retrieved from electronic health records. But the post-marketing information about drug efficacy are not available, and information such as adverse events may not be readily available from electronic health record, but they can be retrieved from secondary data sources such as FDA adverse events reporting systems. And the demographics, encounter, diagnosis, procedure, they're all some really very typical information from electronic health record, and most of them are well structured and standardized using standardized medical codes. So when it comes to analyzing the data using electronic health records, this information are some of the information that can be relatively easy to use and relatively easy to retrieve. And the information such as genetics and social history, family history, some of them are available at the EHR, in different kind of coding, but some of them are not readily available. So research efforts, nationally, have been trying to create research assets that link those data to genetics, to family history, to social economic and social determinant health information. So we're going to talk about some of our efforts and some of our prior experiences linking the data from electronic medical records to National Registry of Disease Registry and to social determinant health from using geospatial linkage methods. And if we look at this dimension between the structured data and unstructured data, there are also a lot of data that are structured that can be delineated into different columns in Excel spreadsheets. And some of this data are not structured, like, for example, clinical notes, clinical narratives, blogs, tweets, Facebook postings. Those data are not structured. You will need to analyze this data. We oftentimes have to rely on techniques such as natural processing to process and to extract information that are related and relevant and that are also important for that particular research purposes. So why we use EHR data for prediction models? And we're really trying to translate like real world data to real world impact. And it is known that um, roughly about 30% of data being generated today, every day, is related to healthcare and health. And however, the use of health data to inform health decision making or inform patients' decision making is a very small proportion of it. I mean, there's still a lot of data that are just sit there and not being used for improving care. And the hospitals typically would use health record data to develop like their quality improvements projects. But as a research community, we're really interested in using health record data to predict, for example, disease risks, to find subtypes of conditions, and also to figure out, for example, how to better tailor treatment to individual patients based on their, individualized characteristics. So that is mainly used for precision medicine. So and also, you can also use electronic health record data to find a cohort for patient recruitment. So, for example, if you have a clinical trial that you can directly recruit from hospitals, you may want to use electronic medical record data to find patients that meet your eligibility criteria, so you can include them into a study, and that potentially will accelerate your recruitment process significantly. And in order to do that, you also have to work directly with hospital systems and the healthcare setting. So these are just some of these examples about how to sort of like use where prediction models really fit in the learning healthcare systems. If you know about learning health systems, it's really like a kind of a loop where you kind of collect data at a point of care, and then you kind of sample this data to make sense of this data and to make this data usable and understandable to inform clinical flow and practice flow. And then those insights that are generated from data can be used for improving healthcare systems and operations, management of care, patient care, decision making for care. So this whole loop really create like a really healthy circle of information. So through this learning healthcare systems, data-driven discovery is really important because informed by data collected, we can better understand those insights. So things like cohort discovery for research, you can also do risk stratification to figure out which patient would need a specialized care and how can you make sure that the patient get adequate care to improve outcomes, to reduce, for example, hospital readmission, to reduce mortality. Those are some of the fundamental goals for healthcare. And CDS support, clinical decision support, has been around for many years. But in the recent few years, because of use of AI tools such as automatic scribing tools for taking notes for patients, for clinicians, significantly reduce the time like clinicians interact with the records. Because it used to be the case where clinicians has to spend more time entering information into your EHR than talking to the patients for recording their information. So there's a lot of needs for using EHR data prediction model in the learning healthcare system paradigm. And the overarching process of the data being used for decision making, it can be simplified as getting data from point of care, from behavior data, from genomic data, and then performing data analysis to generate evidence and insights, and using those insights to improve outcomes and reduce healthcare cost. So some of the interventions can be informed by data-driven discovery so that we can provide the right intervention to the right patients at the right time. So for example, recently we have got funding from NIMH to do this HIV prevention for young adults. So we're using both the qualitative methods such as group model building to interview clinicians and patients to figure out what kind of barriers and facilitators for patients to engage in HIV care or prevention care or treatment. And then we can use data-driven discovery to use electronic medical records to find these causal graphs, to find the all these nodes that potentially can lead to a prevention outcome for HIV, which for HIV care, it's like use of pre-exposure prophylaxis, but for other diseases, it could have other type of indicators for care engagement. So we can use this type of data-driven methods and see what intervention points will be appropriate for the particular subtype of population, and then we can see how this could be used to inform the intervention design in the future. So At the same time, the data are available through the research, academic research centers and also academic health centers. Many of these big hospitals and teaching hospitals, they have transformed their data in electronic health record into different formats. So the two common formats are the National Patient Center Clinical Research Network, PCORNet, and another format is called OMOP Combinatorial Model. So PCORNet is a PCORI supported and promoted combinatorial model data structure, data framework for structuring EHR data. So your data from different hospitals will be formatted in a similar form so that you can run a same query for the cohort in different sites. So the data doesn't have to be shared across different clinical data research warehouses, but rather you can apply the same query to to find a cohort and to run algorithms and prediction model codes and to generate your prediction outcomes and to validate methods or to kind of adapt the methods. And OMOP is a data warehouse that is created by a private public partnership. And it's been out there for I believe for more than more than uh, more than 15, maybe 13 years since when I was at Columbia as postdoc. Columbia had this relationship with Janssen Research. So there's like a researcher from both Columbia and Janssen. They kind of promoted this idea of Odyssey. So OMOP has been now used globally by more than, I believe, more than hundreds of clinical healthcare facilities and organizations. And then nationally, research effort, kind of big research warehouses such as All of Us, which is NIH promoted resource and the National COVID Cohort Collaborative. Both of them are adopting OMOP kind of model as their fundamental data models for their data infrastructure. So examples I want to share with you is I want to give you a few examples about data warehouses. How can we use these data warehouses for research? So one research resource is called the National COVID-19 Cohort Collaborative, and this called N3C, an effort was created because during the COVID and there's a huge need for getting all this type of data from different healthcare systems together in a centralized data warehouse, so people can use data warehouse to find sort of the effective treatment for COVID, prevention for COVID, reducing the mortality and reducing the sort of the rate of serious infections among patients in different locations in different subgroups. So the data warehouse was created in a very fast way. And the reason for that to happen is because even before COVID happened, all the different healthcare systems have already created their own instance for data warehouses in OMOP or PCORI or TrialNetX. So OMOP, so N3C has this data coordination center. They are able to ingest all this type of data from different formats into their harmonized data warehouse in OMOP combinatorial model format. And then they're releasing this data through limited and safe harbor data sets to kind of researchers. So instead of getting this data dump into Excel spreadsheets to researchers, they created this centralized data enclave. So people will just have to log in the systems and they provide all the compute resources, all the tools you will need to run your code, to generate cohort, and to run this analytical pipelines, and to produce some research output. And at that time, they also created like a very strong ecosystem where they have a different like disease area specific focused subgroups. And you are, for example, you're working in diabetes, you're working in hypertension, you're working in HIV, you're working on pregnancy. They all have these kind of different subgroups, which are including researchers who are interested, specialized in the area, and they encourage people to collaborate on projects. So they can share their workbook, they can share their note and code across different organizations. So it's a very robust system to enable research collaborations across different organizations, institutions. And they also provided data into different tiers. So, they have tiers like de-identified data tiers, limited data tiers, and restricted data tiers. Depending on your access level, they require different access, sort of IRB approval. It's not necessary for the limited data. It's not necessary for the de-identified or synthetic data tier, but if you want to access limited data tier where you get access to patient real dates of service and real location, you have to get RB approval for that. And FSU at the time, we help with the creation of this N3C institutional data usage agreement, kind of to create this between FSU and N3C. So all the FSU researchers are able to access N3C platforms by using their FSU login to log in the system. And it was actually interesting. Like last year, N3C COVID collaborative was sort of suspended for a few months because of lack of budget, lack of funding. But I heard that they actually reopened it this year to the research community because they figured out a way to make it a sustainable resource. So this is just like providing some sort of data oversight. So we have institutions contributing data, and they have a RB, they have a data transfer agreements, and then they harmonize data, and then they provide data into different tiers, synthetic data tiers, de-identified data tier, and the limited data tiers. So as I mentioned, if you're using data in synthetic data or de-identified data, you don't really need study specific RB. You just need to provide a data use request, and they have this committee to approve your request, and you can access state data. But if you have limited data access needs, you have to have both data access committee approval and also the user project specific RB approval to get access to that particular data. So there are just here are just some example studies that are published in top journals using N3C data. So this paper was published in 2021 in JAMA Network Open. That is focused more on like a clinical characterization and prediction of clinical severity of SARS COVID-19 infection among adults in different regions. So as you can see, because this is national data, and you can stratify analysis by different regions of the country. You can stratify your analysis by different treatment, different severity, different age groups. So it's a fairly comprehensive data. I think at the time of this publication, N3C data at the time, I think I remember it has about 6 million patients, but now I think it has more than 50 million patients in the data cohort because it not only includes patients who have HIV infection, but also includes everyone with HIV test. So the patient may not have HIV diagnosis, but as long as they have HIV lab test, they'll be included in this data cohort. So it's a very big cohort, and it can grow substantially over a very short period of time. And this study was published also in Journal of Clinical Oncology, the top tier journal in cancer. So they published a study focused on outcome of COVID-19 patients with cancer. So you can see they have a very specific definition of cohort. And I mean, this type of definition is also flow is also very common in many other like EHR related studies where you have a bigger population to start, and then you can define cohort based on diagnosis code of a disease of interest, and you can include or exclude patients based on different criteria, and then you can kind of stratify patients into like for example in this project, they stratify patients put into the COVID positive group and COVID negative group, and then based on the index date, they further exclude patients because they want to make sure that patients have COVID, maybe before cancer before COVID infection. So based on that, they want to they further exclude patients in this way. So then they look at their survival probability over the period of after COVID infection to see whether patients with COVID have a higher survival or lower survival compared to patients with no COVID. So obviously, you can see that here patients have a lower survival probability for patients with HIV. With COVID and with cancer. So this also a sub-analysis stratified by different subtype of cancer. Breast cancer, hematologic cancer, prostate cancer, GI cancer, multi-site cancer, skin cancer. So you can see the differences as well. And another research data warehouse and with EHR data is All of Us. Not sure how many of you have heard of it, but it's actually a very prominent national research data cohort. They're trying to simulate what UK Biobank is doing by collecting data from electronic medical records, from genetics data, from behavior data from Fitbit, and also from health surveys. So it's a big mission. Initially, it was called the Precision Medicine Initiative, initiated in 2015 by President Obama, and later retitled and rebranded as All of Us Research Program. And they have similar approach for harmonizing data from different sources. So all this different data from EHR, from health survey, from measurements, from Fitbit are organized into a curated data repository, and they provided also the majority of their EHR, they provide their EHR data in the community model format, OMA community model format. And the good thing about all of us is that they provide a lot of documentation. So you pretty much can follow their like documentation tutorials to do a lot of your research. And also they also provided their data in a data enclave. So the compute infrastructure there, they also give you free credit to use. You want to run queries to run some initial analysis. They allow you to build both Python script and also building both R script over the data infrastructure. And you can also save files into their kind of environment as temporary files. It's a pretty comprehensive data. So this is a snapshot of their data. So you can see that they have condition, drug exposure, labs, procedures. They have roughly 300,000 patients with those informations. And then for the measurement, they have physical measurements, Fitbit. They have about 500,000 patients with physical measurements. So they do actually physical measurement in person. And then the Fitbit data is collected from 50,000 patients, participants. So they can measure their heart rate, their activity level. So if you want to look at physical activity level, walk steps, those information you can get from Fitbit data. They also are increasing their genetic data. So now they have about 4,100 participants with genotype array data sets and about 97,000 patients with whole genome sequencing structural variant data sets. And for health survey, I think the data is very big. They have a lot of patients who answer those health surveys on like lifestyle, health care access, personal information, personal health, and the social factors. So if you want to look at combining EHR data with social determinant of health, I think it's also important to think about using all of us because this is probably one of the best data you can use for national representative sample with data from good data from both EHR, from national health surveys and Fitbit. And we're right now looking at the use of it to figure out whether it's possible to look at older adults risk factor for cognitive impairments. So again, they provided data into different tiers. So public tier is a fairly like aggregate data. There's no restrictions. You pretty much can get access to this data through their interactive tools. And for registered tier, and this is provided as individual level data. So FSU again has this institutional data usage agreement with all of us. So you can actually create an account using your FSU account. And with this institutional data usage agreement, you are able to access the registered tier data. And for the control tier, because control tier would include data for whole genome sequences data, long read WGS structural variants, genotyping arrays. So they require a more special kind of approval. So I haven't really done anything with the control tier before, so I'm not quite completely sure about the process of getting access to control tier data, but there's a path towards that. So to create a project, you basically create a workspace, writing a summary, writing some basic information about your study, and then you have that workspace. You can create a cohort by providing your, for example, diagnosis, demographic data, and other information you want to include in this cohort discovery tool. And then they give you this access to this cohort. They give you the cohort visualization breakdown by gender, age, race, and then you can use this cohort to create like Jupyter Notebook for Python or R, or if you're familiar with R. And for Python, what happens is that they basically put this cohort into a data frame. So all these variables are in the data frame. So one data frame for EHR, one data frame for survey, one data frame for Fitbit, and you can manipulate the data the way you want. You have, I think that some sort of subject ID there that can connect patients from, connect data from different modalities. So that's very very handy. So another data sources I want to mention is called Mimic 2, Mimic 3. Mimic 3 and Mimic 4, those are two very popular data sets for public available EHR data for research and for education. So this was published and provided from MIT Laboratory for Computational Physiology. It's been around for many years. I think when I came here in FSU, Mimic 3 has already been there already by 2015. So it's maintained really well. So in order to access it, you just have to finish MIT's CD training for this particular data set, and then you request access, and you have to provide it. If you're a PI or professor or postdoc, you don't really have. I think postdoc probably for postdoc you have also provided. You have to also provide advice information, but for faculty you don't need to provide. You don't need to provide advisory information. So once you get approved, you'll be able to download this data. It's a pretty big data set. It's like 40 gigabytes of data into your machine, and you load it to your databases, either MySQL, PostgreSQL, or other database systems, and you can run the code. And I believe they also have some sort of a cloud version of Mimic which you can access data. So it's an ICU admission data. So they have ICU data from single center, from Beth Israel Deaconess Medical Center, and they have data from 2001 to 2012. So they have structured data from labs, vitals, medication, procedures, diagnosis. They also have clinical notes data in the data warehouse, and it's been used by hundreds of projects so far. And the thing is, because it's ICU data, so patients there are typically sicker than the typical patients you will see in hospitals, and also it's limited because it's single site that study, and the data is roughly older because you can imagine now we are in 2026 and the data was from 2012. So I think it's very good for education. So for example, if I'm teaching a data mining course, I can use this data to help my students learn how to use EHR data for machine learning. I can tell them, okay, please kind of build a model for mortality for heart disease patients. So they can use the ICD to find heart disease patients, and they can kind of create this data frame, find out outcomes for mortality based on their death data, and they can just kind of using the data for their predictive model pipeline building process, and which is good for education. Not very good for for research grants, honestly, because data is pretty limited. But more recently, they released Mimic 4 data, which is a updated successor for Mimic 3, which provides ICU stay data and hospitalization data. So the data is more current, and also improve the schema, which better modularization. So they kind of separate hospital data with and ICU data. So now you can actually access their hospitalization data. They also include a specific emergency department module. Again, it has data from both structured EHR and unstructured data, and the data is completely free. You don't have to pay anything to access data. So, by the way, I remember the data actually is more than 70,000 patients, right? It's like 400,000 for hospitalization.
Yeah.
Yeah, it's definitely 70,000 is only ICU stay.
ICU stays, yeah.
But their hospitalization data includes more than 400,000 patients, I think, in their data, patients in their data set. I think both Mimic 3 and Mimic 4 also provide like waveform data for physiology data. So if you want to look at ICU stay, for example, in same hospital, you probably they will measure your EEG, ECG signal. So you can get that data as well from Mimic. Another data set is called One Florida Data Trust. So One Florida is a data that we are supporting here, and it's it's maintained by University of Florida, access through their front door services. So if you search for One Florida, you can get access to their front door web pages where you can submit a ticket, and they can give you some information about their services and data sets. And as CTSA Informatics Core, we also provide support for access to One Florida. So if you have questions you want to ask, you want to see whether One Florida has data available for research, we can help you run a data discovery queries using I2B2, which is a tool for using diagnosis, these different codes to find the cohort. You can figure out whether the cohort is adequate for the research questions, and then you can submit a data request through them, either kind of generating a quote for data access because this is not free. They kind of charge fairly hefty fees these days. I mean, they recently increased their fees for a research project. And it used to be that you want to get a cohort from one Florida for about, maybe several 70,000 patients with HIV or 300,000 patients with ADRD, Alzheimer's disease. I think it costs about $5,000 to $10,000 in the past. But recently, because they kind of increase the fee to make it comparable to other P4 site, so the fee is now like about $10,000 for admin cost, and then they can add on it the hourly compute cost. For their team to develop queries, to run the queries, to generate cohort prepared data, they kind of charge based on hours. So they're estimated at roughly like $30,000 per cohort. So if you want to write a research grant to use one Florida data, you will need to submit a request, and they will run the cohort discovery queries, and they will give you an estimate about how much would be needed for you to get the patient level data from one Florida for your research project. So I would typically think that this is necessary. This is a good resource. You have planned to write like federal grants or state level grants, that you will have that kind of budget to be able to purchase data from one Florida. It's not like a cheap resource, but it's very rich, because now like they include data from Florida, 20 plus hospital in Florida, hundreds of clinical sites, Medicare, Medicaid's cancer registry. They also have data from University of Emory University from Atlanta, the data from University of Alabama, Birmingham. They now also include Minnesota, including University of California, Irvine, including I believe other sites. So they call it one Florida plus, which means that it's a Florida data plus other hospitals and sites from other states. So it's very big. So they have provided data through this central data repository. So all this type of data are presented as a limited data sets into one Florida data trust. And then they presented this as a data research mart, which presented to individual researchers. So you submit the protocol to one Florida steering committee. You get approval for RB approval. So FSU, it's necessary to get FSU's RB approval to get the patient level data. So and then once the data is approved, they can generate data set for you. And technically, you can also get patient contact information. Your patient have consented to share their contact information to researchers. So they kind of run this through an honest broker program, and honest broker will re-identify patients from different sites to be able to reach out to individual patients. But that process is a separate process. So I'm not gonna talk too much detail about that, because this presentation is not really about patient recruitment. And the UF-FSU IDR data is another data that we have access to because we're under the same CTSA. So this is pertaining to UF-FSU Shands Hospital data. I think it includes about 700,000 patients in UF-FSU. So they provided data both for structured EHR data, demographic, diagnosis, procedure, lab results, medication, vital signs, encounter level data. And you can also link this data to claims registries and PRO data. But it has clinical notes data, but clinical notes data cannot be shared across their outside of their cover entity. So FSU colleagues, we cannot have their EHR data here at FSU. So that's a little bit challenging for us to use if you want to use their clinical notes data. And we just simply, they cannot share data with us, to FSU colleagues. And in order to request data, you can also request data from their request form. But I suggest that if you have questions or needs to access EHR data from UF-FSU Shands, please submit a ticket to CTSA at FSU first, so we can discuss with you about what's feasible and what's not feasible, and so that you have a better idea about like what can be done there, and then we can kind of write a request to them formally. So here I just want to present you with some broader idea about how to build a prediction model pipeline using EHR data. So for EHR data pipeline, we typically start with cohort definition. So you want to, for example, focus on particular disease areas. So you want to look at the patient with a specific demographics, specific conditions. You can use those diagnosis, demographic like age range. And also, for example, like you may also want to focus on patients with particular procedure. You can also use the procedural code to find that cohort. And then you also have to identify the outcome. What is the outcome you want to predict? Either it could be diagnosis or of a condition, or it could be like medication adherence. It could be things like mortality, death. It could be readmissions. So kind of really depends on what is the specific outcomes you want to use for your prediction model. So the definition can also be decided at the time of research design. And then once you get the data, because typically for EHR data, we get a bigger cohort and we include all the labs, we include all the vitals, demographics, diagnosis, and then you will need to figure out like what feature do you need based on domain knowledge, sometimes based on frequency. For example, even though we want to look at all the lab results for patients for this cohort as a predictor for certain things, but patient may not have all the labs there, so you may want to look at using frequency filter to find okay which patients have at least a at least we want to make sure that patients a particular lab has at least more than 5% or 10% patients have that particular lab to be included. Because if you included if you include a lab for which very few patients have that, you will end up having like a lot of missing value for that feature, which is not ideal. And then after the feature extraction, you oftentimes have to transform data from EHR from this kind of long format, because in EHR data, typically every record for lab tests, every record for diagnosis for medication is one row in the data for that data table. And you want to build a prediction model, you oftentimes have to convert that into a feature, which is a patient ID followed by the lab test and followed by medication use. That is called a wide format. So the transformation can also be done in a data processing pipeline. And then once you have done that, you can decide whether you want to use classification, prediction modeling, or you want to do clustering. So depending on your specific research questions, you can create data frame accordingly, and then you can make sure that you have the data ready to be fed into prediction models or machine learning models. So this is another like very very traditional pipeline for prediction model. Because EHR, you should have access to both the structured data like lab results, demographics, diagnosis, medication use, and procedures. You also should have access to unstructured EHR data from clinical narratives, because oftentimes information about social determinant of health, for example, or about kind of family history, about social context may not be readily captured by structured data. So you may want to potentially use NLP to extract those data to augment your data from structured EHR. And for patient representation, and then for feature selection, sometimes it's necessary, sometimes it's not necessary, depending on like how many features you have. And then there's a whole bunch of methods you can use for feature selection. And then there's also a whole bunch of methods for classification, regression modeling, and patient similarity matching. One thing I want to mention before we delve into a specific example is you oftentimes for prediction model, you oftentimes have to define your index date. For example, what is the date of the sort of the event you want to use as a anchor date? For example, in one of our previous studies where we predict post-transplantation outcomes, for example, mortality outcomes after the transplantation of an solid organ, we would use the date of transplantation as an index date. So before this, between the date of organ transplant registration to the transplantation date is called our observation window, where we're using this observation window to collect all the factors that could be used for predicting the outcome. So those factors are happening before transplantation date. And after transplantation date, you will want to look at, for example, mortality outcomes or organ rejection outcomes. We can collect those outcomes data from the prediction window after transplantation date. So all this 1 year, 2 year, 3 year, 4 year, 5 year are depending on your study design. It's not necessary that every study have multiple, like kind of a multiple prediction window, but oftentimes, if you want to observe both short-term outcomes and long-term outcomes, you may want to look at multiple year ranges. So in this example in particular, we're looking 1 year, 3 year, and 5 year outcomes as a data collection. So, and then you need to include patients, for example, you want to make sure that patients have enough data in observation window. So sometimes, data cleaning process, you want to make sure that patient have, for example, multiple encounters before the date of transplantation so that you have some data to use as a predictor. And for outcomes, you certainly also want to look at whether patients have encounter after they got transplantation, like after 1 year, 2 years, 3 years, 4 years, 5 years. So for this particular example, because we have this national data for organ transplantation, so they have both the registration information, which we can use for observation data collection, and also they have 1 year follow-up. So every year after their transplantation procedure, they have like follow-up with this, their hospital to for post-transplant care. So we have all this outcome data for rejection, for graft failure, for mortality. So we can calculate the data in the outcome prediction window. So sometimes you may also have mixed of outcomes. So you can define different outcomes and build different models for different outcomes. And for efficient engineering, there's also a lot to discuss. We can look at lab results data, how to structure, how to analyze it, analyze vital sign data, how to do medications, how to analyze diagnosis data. For example, one thing to consider is because oftentimes patients may have multiple lab tests done in the prediction windows. So if you want to look at that as a feature, you will need to decide whether you want to look at the aggregate labs within the observation window. So we want to do that for aggregate data. You can look at using mean value for particular labs, or using mean, max, minimum, max, maximum, mean value, median as a summary statistics. And for some models, if you want to feed the data in the raw format into a deep learning model, such as long short-term memory models, you can use a raw data, so the data can be fed into the model as a sequential data, as a longitudinal time series data. And that also happens to vital signs. But for medication diagnosis, oftentimes this type of data may not be changing too much during the observation window or diagnosis or prediction window. So oftentimes you don't really have to worry about longitudinal data dimensions. But for unstructured data, for clinical notes, radiology reports, progress report, we oftentimes have to apply NLP to extract key features and augment the structured data with these key features from extracted from unstructured data format. And there's a lot of things we can talk about. I think when we get to the case studies, I will let Balu talk about how we engineer those features as well. So something to mention, including data leakage, could be a big issue when it comes to prediction model. As I mentioned, because for EHR-based prediction model, you want to predict future outcomes using past data. You want to make sure that your data for the outcomes are not seen by your prediction model when you train the model. So you're not really mixing the prediction window and the observation window. You want to also make sure that you kind of when you create random split, because one best practices for prediction model building is called cross validation. You can either do fold cross validation, where you split the data into 70% training, 30% testing, and this testing data do not have any patients in the training data, and that is commonly used. And you can also do 10-fold cross validation, where every fold you get 90% as training, 10% as testing, and in another fold you flush the data model, flush the model, and then retrain the model using another random set of 90% of training data and 10% testing data, and do it for 10 times. And another approach is to using rolling-based cross validation, where because the data is longitudinal, so you can kind of move your index date. For example, every beginning of year, you can use that year as an index date. So the date before that is the prediction window. The date after that is date before that is observation window, and the time after that is the prediction window. And you can roll this over years to create these models for individual years, and you can run that as well. So there's different way of doing validation and training validation. So but just make sure that you don't have you don't have your model see the outcome before you actually using the outcome for prediction. So I'm gonna skip this a little bit. because it's probably too much complex to describe in this meeting. And for model selections, for baseline models, we have different machine learning models that can be used, like logistic regression models, Cox models, like regression models, and like support vector machine models, random forest. Those are some of the machine learning based models, neural network models, XGBoost models. They're also commonly used models for machine learning based methods. And then for evaluation, you should use areas under operating curve, receiving operating curve, areas under precision recall curve, calibration curves, and decision curves for evaluating the model robustness and accuracy and discriminability. So this one is example of a calibration curve, which shows the friction of positives among the positive classes and over the mean predicted probability. So the ideal curve is is on the dashed line. So your actual prediction would kind of fluctuate, around this a perfect calibrated curve. So if it's too different, it means maybe your model is not that robust, and you want it to have the curve that is closer enough to this perfect calibrated curve. So the explainable AI models methods. Because machine learning models like random forest, XGBoost, neural networks, those are typically not really explainable because they don't operate like logistic regression or regression model where you can use the coefficient to estimate the weight and the importance for individual predictors or independent variables. And for random forest, XGBoost, and neural network models in particular, you really want to use explainable AI methods to explain how the model performs because the end users or clinicians really wanted to know on a global scale, like how the models make predictions based on what features, and also on the local scale, like for each individual predictions, how the prediction is made based on what features. So in 2020, we actually published one of the earlier papers in the systematic review papers in the space to summarize and categorize the methods for explaining AI models using real world EHR data. So we kind of categorize these methods into explainable models, scope of explanation, and type of explanation. So here I'm just going to be using the scope of explanation, which is simpler to explain. So there's also like a Triple AI 21 tutorials about Explore AI. So if you're interested, you can also using this URL to access this tutorial for explaining AI models. So this one shows you an example like a sharply value explanation for models. So this tell you for each individual features how the values of individual features contribute to the prediction, either positive prediction or negative predictions, and the color represent the actual value for that particular feature. So, and this is another example showing you how the global interpretation can be achieved using Sharpe values. So the global interpretation can explain overall model behavior. So you can think about similarly as using odds ratio for logistic regression coefficient. But the Sharpe values cannot be easily sort of interpreted the value that closely with as an odds ratio, but it can give you the idea. So here you can see that the lab value like calcium, if it has a like higher value, it can push the model towards prediction as a negative outcome. And if the value is like lower calcium value, it kind of push the model to make a positive prediction. So I think the likely for this prediction is maybe mortality. So it means that the lower the calcium, the worse for prediction. And similarly, for age, it means like the higher the value of age, the more likely the model will push the prediction to be positive. If the outcome is like mortality, it means that if people are older, it's likely the model are predicting this person to die within maybe 1 year, right? So similar to glucose, platelet, I think to a certain extent, it kind of makes sense to have higher glucose, higher chance for mortality, lower platelet, higher platelet, higher chance of mortality. So it can give you some ideas about global interpretation. And then for local interpretation, it can give you information about individual patients' prediction. So for example, for this particular person with this particular labs and demographics, it can tell you like because the patient have age 47, glucose value of 82, and I'm not quite sure what is RDW, but you can see that those values are generally pretty healthy. So they kind of, because of this value, they push this model to predict this person to unlikely to die. But because of these values like calcium, WBC, platelet count, and the bicarbonate, because those are mostly like abnormal values, so these values are pushing the model to predict the person to be likely to die. So you can see that kind of this changes, and you can use it to interpret individual person prediction. Sure, Sanders. Grace, yes, I will record this and I will send this to folks, through CTSA channels afterwards. So it's being recorded for sure. And then this is called a Lime explanation, which give you also another way of explaining models of performance for individual patients. So this person have a 94% survived rate based on the prediction outcome. And this one features using Lime also show you why the models predict this person to have a higher chance of survival because of good calcium and low glucose and good bicarbonate and good BON and good WBC values. But for those abnormal values like higher age, not abnormal, like high age, high HCT, high NTW, they kind of push the model to predict the person to be die. So you can see this also makes sense to a certain extent. And then there's also a trade-off between accuracy and interpretability, because for simpler models like regression model, decision tree models, those are more interpretable because you can use this either rule-based methods or coefficient to figure out like why the models perform as such. But for more complex models are less interpretable, but they're more accurate. So there was like a paper published back in 2019-20 about like do we really need complex models to have very good interpretability? Can we live with models that are highly accurate, highly complex, but not quite interpretable? So they're kind of framing this as like dealing with high stake applications or low stake applications, based on the actual outcomes being predicted and also the actual decisions being made to patients. If you're interested, I encourage you to read these papers to get better insights into this phenomenon. So here are just some examples. I want to quickly go through some examples that we have published in the recent few years on using EHR data for predictive model. So this paper was published in 2023 by my student For Han, and the idea is to predict early mortality of hemorrhage patients, stroke patients. So we're trying to use demographic data from MIMIC3 data, lab chart values, and also some vital signs to predict 7-day mortality within ICU stay for patients admitted to ICU because of intracerebral hemorrhage stroke. And then we're using several deep learning machine learning-based methods to build models for predicting mortality. So for the model setup, this is important that we have to determine what is the observation window and what is the prediction window. So we're using 1 day of ICU stay data as prediction to predict whether patients actually die in any of the 7 days after ICU stay. So certainly, as you can imagine, we will have to make sure that patients have diagnosis code of this disease using ICD-9 codes, and also exclude patients who died within the first 24 hours or after 7 days because those patients are not something we want to include. And then after that, we also exclude patients with missing values or inconsistent values for certain variables we're interested in. And also we also include ICU stays after sampling. And then for the remaining patients in the data cohort, we can split them into training data and the testing data. And we build models and we report on the precision, recall, F1, accuracy, and AURC. And I'm not going to detail about the model configurations because the ensemble model essentially are kind of merging the data that are fed into a kind of longitudinal data model using LSTM compared to using the deep learning methods. So this paper was also published in 2022, and the idea is to using Alzheimer's disease patients' EHR data to create different subtypes of disease based on what kind of conditions that happens before their first ADRD diagnosis. So what we did for this was we look at AD diagnosis in the beginning, and then make sure that patient um, uh, have their first diagnosis of AD, have a date of the diagnosis, and then we want to make sure that patient have some condition information prior to the first Alzheimer's disease diagnosis, and then we look at 40 phenotypes, the disease areas or disease by mapping those diagnosis code into phe code, because oftentimes those diagnosis code of different subtypes of conditions can be grouped together to create like more coherent like group of diagnosis. And then once we did that, we look at whether patients will have their first AD diagnosis above 20 years old. And then we might make sure that patients have at least 3 years of data before their first ADRD diagnosis. So end up downsizing the patient cohort from 120,000 patients to 29,000 patients. And then we look at every 6 months before their first diagnosis of a Alzheimer's disease, what kind of conditions they were recorded, they have had in the past 3 years. So we created this kind of data frame matrices, and then we using the spectral clustering methods to cluster patients into different groups based on what kind of condition they had prior to a DRD diagnosis. And then we look at using regression model to find the correlation between demographics to their ADRD subtypes. So we found there are certain groups. We created 4 different clusters. The fourth clusters contain mostly patients with hypertension, dementia, and the second cohort having patients with a mix of conditions. And the third cohort has even diverse patients with even more conditions. So we also created longitudinal cohort subtypes, looking at each of these sub cohort, what kind of conditions patients have in the past six time slots, 3 months, 3 years. So you can see that the first type contain patients with a long history of hypertension and type 2 diabetes. And the second one having patients with a very short cohort, short diagnosis of dementia and hypertension and a mix of other conditions. And the third cohort, third type contain recent diagnosis of dementia, long history of hypertension, and not other conditions. And the fourth one contain long history of hypertension, short history of dementia, and also a fairly mix of disease in the area. So that's the case study I want to talk about, and then I'll give Balu an opportunity to mention 2 other studies that he worked on in the past 2 years.
Thanks, Dr. Shah. So once again, hi everyone. I am part of the CT team here at FSU, and I will be discussing today's 2 case studies we have conducted using the data sets that Professor has already been discussing. So for the first study, we are focusing on All of Us research program. Someone is coming, yeah, joining. All of Us research program data, and All of Us is basically a National Institute of Health initiative to collect data throughout United States with an idea of improving precision health by combining data from whole genome sequencing, electronic health records, Fitbit data, physical measurements, and survey responses. So it's a diverse data set. It can be basically used, applied for like disease progression identification, treatment effectiveness, clinical trial mapping, and even to help basically better improve the patient's outcome. So to give a quick overview compared to the previous introductions, once you will sign up with your, for example, your FSU ID, once you get access to it, you can access this public tier. Public tier contains all these EHR, physical measurement and survey responses. And if you really want to explore the whole genome sequencing and genotype arrays, you want to complete another level of training and expected to complete some question answering. And once you pass the exam, you will get access to the control tier, and it is stored in like a Google Cloud sequence data. You can basically, everything is connected to a single patient ID. So if a patient has both EHR, physical measurement, survey, and the whole genome sequencing, you can combine everything together in your data frame using the common patient ID. And you can use this All of Us NIH URL to log into the site. So what I'm going to today discuss is the first case study using this specific data set, and our objective was to predict HIV diagnosis among emerging adults. The study is published in BIBM, the Bioinformatics and Biomedicine Conference in 2024. And so this is a case control, retrospective case control study, meaning that we have a case definition and a control definition, and we are looking back the period from the index date to identify the data from all of us to build a machine learning model for the prediction. So the definition was individuals in between the age of 18 to 29, young adult cohort group with HIV, ICD codes and relevant medication history and lab test without any use of PrEP, which is a medication used for basically to who will not get that kind of a HIV. It's like a precaution medication. So we do not want those kind of patients within our cohort group. So initial screening we did, and around 492 patients were included at the final cohort, which is based on certain inclusion exclusion criteria. And our control group was people with high risk group with all the related sexually transmitted disease, psychiatric condition, substance use, etc. As you can see, the cohort is 64% were male, 55% from Black or African American, and around 21% of this case cohort was from Hispanic or Latino ethnicity. So to give a better context about what we are trying to do here, our case definition is an young adult group, and we used a condition co-occurrence table from the all of us research database to identify all the ICD-10 codes with connecting the HIV diagnosis. And we are also looking at a particular survey responses. The survey ID is this one, to get a personal medical history information that are you currently prescribed any medications related to HIV, then certain HIV labs like CD4 count to make sure that they have enough like lab test covered to have HIV diagnosed, and some drug exposure to remove some exclude some certain set of patients. So the initial search identified 780 patients. Then we did some exclusion criteria at multiple checkpoints to finally reach out 492 patients and who have HIV diagnosis based on our phenotyping algorithm and have at least EHR data before three months prior to this particular diagnosis. So we are treating index data as the HIV diagnosis date based on this search. And our control cohort is on the same age group, young adult with like high risk group, or the sexually transmitted diseases, anxiety, substance use, and other diagnoses who may get HIV in the future. So we combined this cohort into around 38,000 cohort patient group, and to get a balanced data set. But in sometimes in case of machine learning prediction, you may have to have a balanced data set to get models more interpretable and high predictive performance. So we kept the whole data of the ICD codes for the patients as it is for 92 cases, and 3 times the size of the cases as controls from this 38,000 cohort. And as Professor J. early said, we in a general practice is that we keep 70% of the data as training and 30% of the testing. So the patients who are present in the training data will not be present in the testing data. The model will be trained to learn the patterns from our clinical parameters from this training data, and a newer set of patients will be introduced during the testing time, and to see what model identifies as a positive HIV patient or a negative HIV patient based on their clinical data. So this data is from August 14, 2024. It was, I think, all of us version 7. Now all of us has a version 8 refresh. We were using EHR information along with certain set of survey data. So for the electronic health record, we collected information from multiple tables for demographics, diagnosis, medication, lab test, observation, procedure, and certain set of survey data. And we combined this information based on the patient ID, and all the EHR components were extracted based on the highest number of frequency among the cases and controls. So data pre-processing, we treated all variables as binary. So when a patient has abdominal pain, headache, or asthma, if their ICD code is mapped prior to that index date, we will set it as 1. And if that particular diagnosis is not present, we will set it as for 0 for that patient. That is what mean by a binary one hot encoding. For lab values, it is like numbers, sequence of numbers. Hemoglobin can be basically tested multiple times throughout the year or maybe multiple over the years. So we normally get a median value of the data for the observation window. And for the survey data, we have calculated an AUDIT score, which is prior to the other literatures. We followed, combined multiple survey questions and came up with a score called Alcohol Use Disorder Identification Test Conception Score, generally known as audit score. And prior literature were also showing that people who have like heavy alcohol use tend to have more complications with HIV. So we used this particular scoring based on 3 survey questions identified from the survey data from all of us. One was like their daily drinking habit, how many number of drinks they are having daily. And based on that, there is this particular scoring mechanism follows a number, and how many of the drinks they have past year and how many drinks they are having in like in their occurrences in the past whole year as well. So based on this scoring, if a person will be mapped as a hazardous drinker, if the person is a man and they have a score of 4 and person is a woman and the score of higher than 3. So we combined the EHR data and the survey data and to train models within a settings of 70% training and 30% testing. So we generated machine learning models using XGBoost, AdaBoost, random forest, logistic regression, and support vector machine. These were the general baseline models and boosting models that people basically test to identify the model performances in various settings, such as outcome prediction, such as like HIV or not. So we found that based on our data from all of us, XGBoost tend to perform around 90%, 92% of F score, which is a metric used to show the performance. The higher, the better. And we other models also performed similarly around 90, 94, 97, comparable to a logistic regression and SPM around again 80s in the range. So the F score is one of the major metric we tend to follow to see which model basically performs better compared to other matrices, and the score was from 79 to 92%. And we then generated like a feature importance plot for the top 10 predictive features to see which features are coming and how it can be interpretable in a context of a young adults HIV prediction. So SVM showed some drinking habit along with some medication use and some diagnosis. Logistic regression also again shows top features are some drinking habit followed by some certain lab test, family planning, and then some medication. Some other features in random forest, it was mostly demographic features and lab test. And again, logistic regression also, the L2 version also uses certain set of labs as top features. So we basically selected SVM, this first model, for a better interpretable in the context of combining multiple feature spaces. And we created like a ROC curve as previous discussions. This curve basically looks for the false positive rate and true positive rate for each model we developed. And this line is the random guess. Basically, any model goes below this line or near to this line is basically a model which is not good or useful in any clinical settings. And the better performing model are tend to have a higher like a curve like this and very near to this particular point. And each of these curve is developed by plotting smaller points based on the predictions of the whole test set data. So our model was selected as SPM in the context of around 90% of performance as well as some clinical interpretation. So additionally, when we people develop like clinical prediction models, certain set of additional analysis will be done to make sure that the selected model have some more robust interpretations and capabilities. One of the thing people do is called subgroup analysis to look for their bias and in certain settings. So in our case, we look for any bias between male and female or alcohol use versus hazardous drinkers versus non-hazardous drinkers. And we found that when comparing male and female, the performance is only 4% dropping from 84 to 80. And here is that number. And for the alcohol use, hazardous versus non-hazardous drinker, the model again performing same like 85%. So there is no certain fluctuation here. There we also did like a precision recall trade-off analysis, basically looking for at which cut point the model's precision and recall basically drastically goes down. As you can see from here, the model's precision and recall goes down. So 55 can be identified as the precision cut-off point. So what we are generated from this particular study using all of us research data is that machine learning models can identify HIV versus non-HIV patients prior to 3 months using combining data from electronic health records and survey. Key predictors included risky drinking behaviors and which can connect with alcohol use and HIV. This inclusion of survey data basically enable us this because alcohol use disorder or related information getting from EHR data is quite hard. So we were able to get mostly around 80% of patients' responses based on our survey data because all of us enabled that kind of an analysis. And also subgroup analysis saw a strong performance and there is no particular bias towards gender or alcohol use, and cutoff optimization was also reliable for a robust model. So this was the study we published in this IEEE ICBIM conference, and you can explore this based on within this IEEE Expo, which is publicly available to read. So the second case study is using UNOS data, United Network of Organ Sharing. So UNOS is also basically an entity that collects and manages the data for organ procurement and transplantation network, commonly known as OPTN. OPTN is responsible for nation's organ transplant network. So UNOS developed a database called UNET, where basically the whole United States organ transplantation data will be collected, stored, and provided for analysis. And the public use of this UNOS is one of them is scientific research. So they enable data to be collected from their UNET databases and can be used for like various analysis, such as the one I'm going to share in the case study 2. So we combined this data with integrated data repository Professor Jay previously discussed. It's called IDR within University of Florida's research services. IDR is a large-scale database within UF Shands hospital data, where basically using an IRB approval, FSU researchers can get the data. So we basically combine this UF data, the EHR data from IDR with UNOS data, the transplantation data for a particular patient cohort called like pediatric population. So the study focused on the interpretable machine learning model generation for predicting the organ rejection for pediatric heart transplantation by combining EHR data and transplant registry data. So we developed interpretable machine learning models to identify the pediatric heart transplantation rejection as an outcome. We analyzed a combination of clinical as well as social determinants of health data using like Shapley based importance models and assess their clinical utility and performance. The current version of the study is available in medRxiv. We are the kind of communicating this study with a clinical journal now. The study consists of other co-authors from FSU and UF, and Dr. Deepankar Gupta is a pediatric cardiologist from UF, whereas a clinician who provided additional interpretation and suggestions on developing the model. So the objective was to look for pediatric hair transplantation cohort because this is a certain challenges facing cohort where there is limited donor availability, long wait list with mortality, then acute rejection and hospitalization. So existing predictive models may not be able to combine multiple data sources. So we kind of did that with the combination of UF IDR data as EHR and UNOS data as a registry data, and combined the data cohort of around 111 pediatric heart transplanted patients aged 0 to 18 and developed prediction models to see if the model can predict when the organ will be got rejected within 1, 3, and 5 year post-transplant interval. So this data basically comes from transplantation recipients. The data is from the UNOS data, EHR, and we also process the clinical notes from the IDR data using a package called Social Determinants Package SODA, where we try to map the clinical variables that are extracted from clinical notes. So we get all the information about gender, living condition, education, etc. So that the prediction model will be more enriched, because in certain contexts, such as hair transplantation, the patient's care, their like transportation availability, all these things connected with how they are medication adherent, their follow-ups are correctly done with the hospital, etc. So we kind of combined the approach of UNOS transplantation, EHR plus social determinants of health to generate machine learning models for this particular task. So as previously discussed, we need an index date. Index date is the date of transplantation here. We are looking back up to the date of registration. As the look back period, we are looking for registry data, phenotypes, medication labs, and SDOH within this particular time to get the data. We also looked for their pre and post transplant labs and 1 year of medications. This is added to the study because clinicians were suggested that post transplant there may be some complications, and patients may are in certain set of medications, and that medication can indicate the complexity of the transplantations and the current medical condition of the patients, which may play an important role in the rejection for 1 year, 3 year, or in a long time 5 year rejection. So regarding the patient cohorts, our cohort contains 111 patients. This data is a combination of data from both UNOS and EHR. 63% of were male and 36% of were female, and around 51% of from white race, and then followed by other races. And 67% of patients are less than 10 years, and around 45% of patients have one congenital heart defect as a major primary diagnosis. And for the SDOH part, as I said earlier, this is clinical notes of these patients were processed, and we given a criteria that at least 69 or 70% of patients needs to have these variables in the clinical notes. Then only we are including those variables. Some variables have 100% of patients have reported these in their clinical notes. And an NLP package developed at the Young Hoist team at UF did that run, because clinical notes are not shared within FSU and UF. So they did run this package and extracted this information from the clinical notes and provided us like a tabular data that can be integrated to these models. So we included their living status, education, tobacco use, substance use, living condition, financial constraints, transportation, etc., to get more like social aspect of the patient, so that how it can be interplayed during the rejection prediction. So again, we developed these as like a machine learning model outcome prediction. And since the data is smaller compared to that HIV study, we did a 10-fold cross-validation technique, because if you try to keep a number of patients separate as a test cohort, our training cohort may be very smaller, and we thought that the model may not get enough data to get that pattern of identification. So for a lesser cohort, people normally try to do a 10-fold cross-validation. So in each fold, 90% of the data will be trained, and 10% of the data will be used for testing, and mostly AUROC or F-score will be, then all these additional metrics can be generated. So outcome is like ensemble of tuned models, reliable and generalizable for pediatric hair transplant rejection by combining socio-demographic features, and multiple models came in separately, performing better in each 1, 3 year and 5 year rejection. And as you can see, a sequence of models tend to perform very similar in an ROC curve ranging from 67 67 to 76 for this particular example. So multiple like machine learning models were generated. We did not get a higher trend, like some certain models are performing highly better compared to other models. Most models tend to perform within small deviations in the confidence intervals. And then we went for a model interpretability, as Professor earlier told. SHAP is the state of the art. People try to do get the models interpretability. But recent days within this clinical domain, people are giving an added advantage across SHAP-based models by combining a different method called SHAP VIC. SHAP VIC means SHAP variable importance cloud. So this VIC aspect is coming up with not only a single model will be generated, a sequence of models will be generated based on the density of the data points, and it can up to 500, but for our current settings we use the 250 nearly optimal models to generate multiple different models on the same algorithm and look for their kind of like importance across multiple models. So we are kind of averaging the SHAP values for each model so that we get like an averaged SHAP mean score, which will be more interpretable with a confidence interval and error bar. So we were able to generate a SHAP VIC interpretability for this, and this is an example of a year one rejection prediction, and the performance was already around 70-80. So the model is able to perform who will be getting rejection within 1 year, 3 year and 5 year with a good confidence at nearly around 75%. But we want to get an additional context of what features are making that kind of a prediction. So you can see here the major top features are coming as life support, steroid, dial after list and TBL. So what these features means is these candidates life support at registration and their dialysis occurring between listing and transplant, their most recent bilirubin, and then along with transportation. So if we try to like get a like an explanation of these features, this patient, mostly the patients may have like some complex clinical scenarios with some they're already having some needed of life support. They're also their kidneys are failing due, they are expected to have dialysis, and they also have some issues with the transplantation. So combining these features, the model will be able to predict that this patient will get rejection or not within 1 year. This is the plot for a 1 year. We do have plot for other years as well. So that's how we are reaching some interpretation of the model by combining both social determinants along with EHR data. This particular SHAP VIC method also gave more interpretability, so a distribution feature can be generated. So as you can see, the x-axis is the ranking of the features, the top 20 ranks, and y-axis is the number of models that we generated for this particular interpretation. And as you can see, if some models are coming on the left side like this, or like the one we saw, the life support TCR, you can see it is coming on the left side with, so it's a highest ranked feature among all the models, and it is also coming on the left side. And if some features are kind of distributing, means some models are predicting it as higher number feature, but some models are not predicting it. So we are kind of will be averaging in the previous slide, but this is the actual interpretation what's happening across multiple models. So at least we are making sure that the features are kind of more informative and interpretable compared to a single SHAP float from this particular method. So what we concluded from this study is that using EHR data combined with transplantation rejection data along with the clinical node-based SDOH features, social determinants, pediatric transplantation rejection prediction can be achieved a higher performance. Most systematic comparison of the features revealed certain complications such as life support use, illness severity, multi-organ dysfunction such as kidney, indicated like a higher prediction of within the organ rejection for 1, 3, and 5 years. So these risk factors basically also interpreted that immune responses such as some lab test and such as HLA antibody production came as one of the important features. So the clinician interpreted these features and give us some like insights on how why the models are predicting in this way. So in general, specifically for pediatric settings, finding underscores the importance of careful candidate selection and comprehensive family counseling for post-transplantation risk. Clinically incorporating these extended pre and post-transplant observation windows basically enhances the risk stratification, and timely interventions are possible when these kinds of models are deployed in a clinical setting. So I think I will just give some, I think Dr. Zhe can give the summary of the study.
Yeah, sure. So today, we just spent about 90 minutes talking. Sorry for talking through a whole thing. So we talk about the reason why we think EHR data is such a valuable data source for mining insights and also building AI-based models, prediction models for health outcome prediction, diagnosis, and subtypes of diseases. Because of the national effort for creating data sources such as All of Us, that further integrate data from health survey, genomic genetics to EHR data. There's this even better opportunity for leveraging these data sources for a variety of different purposes. We certainly would like to show you more examples, but due to lack of time, we couldn't really do that. Maybe in the future, we'll create more like offline resources, online resources for you to learn about the different use cases of secondary use of EHR data, and we really appreciate you being here. And then today we'll also talk about data processing pipeline and give you several use cases about how we have used EHR data in the past few years for our research project. Most of them funded through NIH. So finally, I want to give you our contact information and also the link, the QR code where you can access our support. So if you would like to ask for help on any of the things like data access or cohort discovery or prediction models, we'll welcome collaboration. So our CTSA services is provided as free 1 hour consultation, and the follow-up services and support are depending on collaboration opportunities on research papers and publications and grants. And also, if you have time, we also appreciate you providing us with a survey, feedback survey on this survey. So just have to scan this QR code to give us the feedback on this workshop. And we do have another workshop in the next month, April 2nd. And the topic is focused on building large language model-based health applications with long chain and long graph frameworks. So if you're interested in using this type of frameworks for building models, building applications for healthcare, you're welcome to join that session. So we already have sent the announcement, so you can check the email, and also we'll follow up with additional announcements on our future activities and events. We're running out of time, but if you have any questions, we can definitely spend some time to answer any questions you may have.
Hi there.
Hi,
Thanks so much for this talk. I was just kind of curious, from your perspective, if you can get a sense kind of for what FSU Health is aiming to create as far as an EHR ecosystem, perhaps creating biobanks for omic analyses, and if there's anybody in particular that's kind of leading the charge for those kind of precision medicine approaches.
So yeah, of course. I know FSU Health certainly right now in a very fast pace planning phase about how to create like data infrastructures for supporting research activities. So I learned from our colleague Dr. Philip Watts from Office Research, who is currently director for our clinical research hub, and about some of the potential, like some of the discussions, activities they are creating for services like health data registries. A lot of things are right now in a I think in a planning phase. So, for example, they are in touch with healthcare systems such as TMH and also healthcare plans such as capital health plans to figure out ways to create centralized data warehouses using their data. So I'm also part of some of these discussions. So certainly there's a capability there because TMH recently launched their Epic EHR systems to replace their previously used Allscript and Cerner systems. So using Epic, it's easier to create data warehouses because the data is more flexible to use. And also you can also create some data pipelines using their more modern system. For example, their FIRE is API supported to get data transmitted directly from EHR to individual health applications. They also have things like Cosmos that give you access to the national EHR data for any hospitals using Epic EHR. They're also creating under the health clinical research consortia, which is currently in a more conceptualization phase. They are creating this type of local kind of discussion service, EHR-based research registry, where we can using EHR data to identify patient and to for prospective research. And they're trying to figure out how to create this data warehouse to host the data. I'm not quite sure at this point, where we are in terms of getting genetic data, because I'm not sure if TMH is actually collecting genetic data for research purposes. I think under the CTSA umbrella, certainly because we have this collaboration with University of Florida. So through CTSA, they have programs such as All of Us sites, and also I believe they also have the other site for genomic data collection. So there's definitely opportunity for collaborations, and so you get access to their data. As I mentioned, we certainly have used UF-FSU data for our project. So I will be happy to help you explore the opportunity for collaboration on their site.
Awesome, thanks.
Sure. Any other questions? All right. All right. So it seems that we don't have other questions. But actually I'm always here. So if you have anything to discuss, feel free to reach out to me, Balu, and we can always schedule meetings to follow up on this. And we'll also make this webinar talk available. I believe they're creating a new website. I think there should be a way to share this publicly to our colleagues. And please just watch for announcements about the release of this workshop recording. So thanks so much for joining again. I will see you next time.
Great. Bye.
Bye.